way, up by the knee. This protrusion is called the tibial tuberosity. Tibial tuberosity on C. So make sure you write that in on your notes. We did not go over that last time. C is the tibial tuberosity.
For the tibial tuberosity, are we only able to see it on this on the lateral knee, or are we also able to see it on the EP?
That's a very good point. That will only be on the laterals. You see the tuberosity. It's superimposed on the AP. We can't visualize it. Very good. So this is a yes.
Oh, sorry. Quick question. For the intercondylar eminence, do we have to do like lateral or medial? Like what the hell?
Just as a whole. Just tell me intercondylar eminence.
Got it.
Yes. Okay, here's a couple more radiographs of the knee, guys. On the left here is just a few more parts that we need to make sure we label. Now, you'll see this J and K referring to two separate spots. So if I ask you to label a knee, guys, I'm not going to ask you to differentiate between medial and lateral. It's a little bit too specific to name. So J and K would both be referring to just simply, once again, the superimposed condyles of the femur. That's just showing you that that knee is slightly oblique. It's not a true lateral. Therefore, you do see those condyles separated slightly, but you don't need to actually identify those on a lateral. You can simply say superimposed condyles. But do keep in mind, when we talk about the APs and the obliques, as we'll see later, make sure you label those as medial or lateral on your condyles and epicondyles. So one more time, on the laterals only, can we say superimposed condyles? And by the way, that's only condyles on lateral. You won't label the epicondyles on a lateral either. Only the condyles for laterals. Now, eye is a very great piece of anatomy. I remember telling you guys about. It's on that posterior surface of the femur. Who did I leave off on? Luke, what do you think eye is? Some at the back of that femur. Smooth surface on the back of that femur.
The adductor tubercle.
So it's not going to be the adductor tubercle. I believe I crossed that one out on your anatomy.
Oh.
Guys, yeah, that was one I told you not to worry about. It's actually going to be the popliteal surface. Popliteal surface. So if you have any arrow pointing to the back portion of that knee that's curving on a lateral view, that's the popliteal surface of the femur. And then over here on the right, this is our sunrise. I'm sure you guys have started learning that in lab. There's a sunrise patella set gas method where you separate the patella from the femur, but we do have some anatomy to make sure we label here. Now let's go ahead and assume this is a left. So A, what do you think A is referring to, guys? A is actually referring to the entire bone. So take note, whenever we look at a patellar view like this, we're not going to see the apex and the base. You're only going to see the apex and the base in a lateral view. When we're looking at a sunrise view, we're simply going to label this just as patella. So if I'm pointing to that, you're just simply going to tell me it's patella, the left patella. B is referring to that joint space once again. That would be the left patellofemoral joint. Left patellofemoral joint. D is referring to the patellar surface. The patellar surface. That's the same as right here, by the way, when we label lateral as our patellar surface. And then E and C. E and C is going to simply refer to the femoral condyles. Now, here's the trick here. Unless we have a double view patella, which usually we do in Harris Health, we'll have two patella views side by side. They'll do it bilaterally. At that point, we'd be able to label whether it is a medial or lateral. When it's singular like this, unless we have a marker, we can't differentiate which condyle is medial and lateral. But let's assume this is a left. Assuming this is a left, E is going to be your medial condyle, C is going to be your lateral condyle. If this is a left. If it's a right, that would reverse, of course. So assuming this is a left patella, E is the medial condyle, C is the lateral condyle. If this was a right, C would be the medial condyle, E would be the lateral condyle. But most of the time within Harris Health, and a lot of the images we will show you, those patella views will be side by side to do them bilaterally with the left and right markers, and you'll be able to easily differentiate what's medial versus lateral. But I'll show you what we're talking about as we move on. So it'll be our sunrise patella view. Okay, let's review our joints one more time here. We're going to classify these here in a second, by the way. So here's our major joints that we are focused upon in this chapter. It's going to be, of course, the patellofemoral joint between the knee and the femur, our proximal tibiofibular joint, our knee joint as a whole, which is simply called the knee joint, the distal tibiofibular, the ankle joint, which goes by two different names, by the way. When we refer to the entire ankle joint separated, that's the mortise. When we only refer to the ankle joint between the tibia and the talus, that's the tibio-talar joint. So let me say that again, it's a little confusing. When we see the entire open joint in the ankle, it's referred to as the mortise joint. When I only see the joint open and it's attached right there at the distal end of the tibia, talus, that is the tibio-talar joint. Tibio-talar joint. And then, of course, we have our three major joint areas in the foot. That's the intertarsal joints, the tarso-metatarsal joints. I'm sorry, four metatarsophalangeal joints and interphalangeal joints. PIP, DIP, and of course, on that first digit, the IP, first digit only. And we're going to break these down here in a second because we've got some different classifications as far as how these fall. But before we do that, well, let's review this real quick because I'm showing you this a lot for a reason. We did a model of this just now. Well, let's make sure we know these tarsal bones. I'm going to hammer these tarsal bones home because, like I told you guys before, the registry loves to ask you about tarsal bones. So real briefly here, guys, who did I leave off with? Naomi, let's name this tarsal bone right here. What is this?
The medial cuneiform
The medial cuneiform.
of the left foot.
Yes, correct. Ruth, what is this tarsal bone?
Intermediate cuneiform of the left foot.
That's the lateral.
So not lateral. What's the one next in line?
Intermedial.
Intermediate. So that'd be the intermediate cuneiform. And then right here will be that lateral cuneiform. So medial, intermediate, lateral. Let me draw that for you so you can see, in case you're having trouble seeing that. Here's our medial cuneiform. Here is our intermediate cuneiform. And then here is our lateral cuneiform right there. Okay. Maricela, which tarsal bone is this one right here?
Not entirely sure.
Cuboidal?
Would it be the cuboid?
It is the cuboid. You are correct. That's your cuboid. Pamela, what about this one right here?
The navicular.
That's the navicular, the left.
The navicular, very good. And then finally, Shibu, what is the tarsal bone right here, closest to the ankle?
Talus. Calcaneus.
Talus?
The talus, you are correct. And then just for fun, because I always got to ask, son, what is this right here I'm pointing to?
Isn't there a calcaneus one?
That's only the metatarsal tuberosity.
Tuberosity of the fifth metatarsal, correct. Good. All right, good. Master those tarsal bones, guys. Please master those tarsal bones.
Mr. Donahue, when you send out the image reviews, you think you can send the answers, like all the answers like in the separate sheet, just because the way you're asking for it is a little bit different from the book.
Sure. I actually, the ones I got you this time, they're all labeled.
Oh, okay.
So I made sure that I took the constructive criticism. I got you hooked up. Don't worry. Okay, guys. So when we're talking about classifying these joints in the lower limb, so all of the joints in the lower limb, with the exception of one, are going to be synovial and diarthrodial. Let me say again, all the joints with the exception of one are going to be synovial and diarthrodial. And if you remember, diarthrodial means what? Freely movable. The one joint in the lower limb that's different from the others is that distal tibiofibular joint close to the ankle. That's going to be a fibrous and amphiarthrodial joint, which means it's only slightly movable. So easiest way to remember, guys, if you know that distal tibiofibular is fibrous and amphiarthrodial, every other joint I might name in this chapter has to be synovial and diarthrodial. Easiest way to study that. Close my shades, the sun's hitting me right in the eyes. So let's go ahead and classify them a little bit further based on their movement type. And we do need to know these different movement types. So when we talk about our interphalangeal joint, the IP, that's any of the interphalangeal joints, by the way, IP, PIP, DIP, they're all the ellipsoid hinge joints movement type. Our metatarsal phalangeal joints, our MTPs, are also ellipsoid hinge joints. The intertarsals, which is the joints in between the actual tarsal bones, are going to be the gliding planar type. Do you have a question, Jonathan?
Yeah, just to clarify, it says ellipsoid hinge, or I thought that was ganglimus hinge.
You are correct, Jonathan. I apologize. That should say ganglimus. I do apologize. Ganglimus hinge. My bad. I'm sorry.
No, just clarify. Thanks.
I'm glad you brought that up. Ganglimus hinge for those first two. I'll fix that before I send you the PowerPoint. The intertarsal is going to be gliding planar type. Ankle will also be ganglimus hinge. Femorotibial ganglimus hinge. And then those last two that we see, patellofemoral and proximal tibiofibular, are going to be the gliding / planar type. Make sure, as always, guys, you know both the names. Both of the names. So ganglimus hinge, gliding planar. That's the only two movement types that we have in the lower.
So the metatarsal the MTP, is that one supposed to be hinge or ellipsoid?
Last ganglimus hinge. I'll double check. That's what my notes said. Ganglimus hinge.
I was just looking at the book. I think it says for the MTP, it said that was the ellipsoid condyloid.
Okay, I'll double check that, Jonathan.
Okay.
Let me write that down. I'll clarify that. I may have made a typo in my notes. All right. Okay, so back to the surfaces of the foot. If you do remember, when we're talking about the top part of the foot, guys, or the anterior surface, that's going to be the dorsum or the dorsal surface. The bottom, of course, the posterior level of the foot is going to be the plantar surface. Now, why do we need to know that? Because there's different ways we actually flex the foot when it comes to specialized views of the foot and ankle. In fact, the doctors will come in and do very specialized view called stress views of the foot and ankle. And depending on what they're looking for, they're going to do what's called dorsiflexion, plantar flexion, inversion, or eversion. I got some pictures to show you exactly what that looks like. Now, dorsiflexion is going to be very important when we actually get to positioning. Dorsiflexion is an actual flexion of the foot that we're going to do for most of our laterals and especially on our ankle views. We flex that foot to open up the ankle joints properly. So one thing techs will make a big mistake on when they're doing feet and ankles is they'll have the foot limp. They won't have it flexed up. So what I'm talking about is if you see my hand, if you imagine my hand's a foot, I'm going to flex my foot up when I'm doing lateral views or if I'm doing ankle x-rays. And the reason for that is I want to open that ankle joint up. Whether I'm looking at a foot or an ankle, I must always make sure that ankle joint is open, because the doctors do evaluate that a lot. And that actual flexing action is what we call a dorsiflexion. Now, the opposite of that, if I relax my foot down and let it just be limp, that's going to be a plantar flexion, because I'm bringing the foot towards that plantar surface versus flexing up towards the dorsal surface. So 2 range of motion there. And then we'll have the inversion and eversion as well, which we do specifically for our stress view ankles. And that's what it looks like right there. When I flex the foot laterally, that's going to be the inversion motion. When I flex it medially, that's going to be the eversion action. Then once you see at the top there, the dorsiflexion is flexing the foot up. Flexing it downward towards the bottom of the foot would be the plantar flexion. So make sure you know the categories of those motions. And dorsiflexion is very important for our positioning. The inversion and eversion is specific for what we call stress view x-rays. That's a star question right there. Make sure you put a star on. Inversion and eversion motions are for stress views only. And on that fact as well, if ever you're out there in clinic and a stress view is ordered for any reason, whether it be a foot or ankle, you as a technologist or student can never actually position for stress view x-rays. That only can be done by a physician. It's a very important fact to remember. You can actually get in a lot of trouble for that. And the reason for that is because of the fragility of the ankle joint when it comes to fractures. Only a licensed physician can actually position for that. There's been a lot of liability issues that have arisen over the years where we've caused further injury to the ankles. Therefore, as the law pertains right now, when it comes to doing those actual stress views, using that inversion and eversion, only a physician can position for those x-rays. So make sure you never find yourself in that situation. If you ever see something that says stress view, you don't want to go in there and position for that x-ray. You got to get a doctor over there to help you out. It has to be done or you can get in big trouble. We'll talk about what those stress views are exactly when we get to the positioning here in a minute. All right, let's do a little quiz here. I'll let anybody chime in that wants to. But let's start with bones. What'd you say? Hey, let me finish the question. How many bones are found in the foot? Let's see, someone's saying 27. What do we think it is, guys?
26.
It's 26.
26.
I'm seeing 26s, I'm seeing 27s, I'm seeing 28s. It's going to be 26, guys. 26. 26. Remember that number. 26 bones in the foot. Which of the following bones of the foot is fractured most often? You guys remember?
Base of the 5th metatarsal.
Base of the fifth metatarsal, right?
You are correct. The base of the 5th metatarsal.
The
It zooms towards your face there. The base of that 5th metatarsal. What is the strongest and the largest of the tarsal bones?
calcaneus.
Someone's saying C. See another C. We're all saying C. Is that your final answer? You don't want to phone a friend or poll the audience? No, it is C. It is the calcaneus. That is the largest. That's the heel bone. The sustentaculum tali is found only what? That's those words I love. I love that sustentaculum tali. I see a lot of A's, and you are correct. It is once again the calcaneus. Calcaneus. Another term for the patellar surface of the distal femur is, we didn't go over this. I just want to see if you knew it.
D.
Oh, we did go over this. I'm sorry. It was one of the alternative names. I thought I didn't mention that. I see a lot of people saying D. You are correct. The intercondylar sulcus. The intercondylar sulcus. And the knee joints. I didn't say this one. I purposely did this to see if you guys remember from back to the very first PowerPoint we had this semester. Do you remember what the classification of the knee joint was? So at the entire knee joint, by the way, not the patellofemoral, the entire knee joint. See a lot of B's. I see a C. It is bicondylar. Write that down. Write that down. So all those joints we just talked about are separate joints. So when we talk about the entire knee joints as an entirety, as a whole, it changes classification to what we call a bicondylar joints. Bicondylar joints. Big star on that. Do not forget that. So the knee joint as a whole will be classified as a bicondylar joint. Okay, so let's talk about our technical and positioning considerations before we get into positioning here. So all of these positions that we'll be hitting in this chapter, every single one of them. In fact, if my memory serves me correctly, every position from here on out to the end of the semester is going to be at 40 inches. 40-inch SID. We will make sure we're using gonadal shielding on all of our x-rays as always, and that tight four-sided collimation because we are doing extremity work. If you're familiar with extremities, we want tight collimation to bring that quality of that x-ray up as much as possible. Correct part and CR alignment is going to be very important for these positions. Part parallel to the IR, CR perpendicular to the part and the IR. And of course, our proper anatomic side markers, and we'll review those as we go forward here. It's a real easy thing to remember, 40-inch SID for everything in this chapter. That's not going to change.
I have a question. I'm just curious, like I already asked him in the lab, but if we do like 40 SID for calcaneus, so we don't compensate the SID?
No, it should still be at 40. And that's something that's a little more of an advanced technique that you'll start learning as lab goes on. When you have sharp angles on the tube, you're going to lessen your SID or lengthen your SID depending on the way the angle is going. And you have to make small adjustments with that tape measure to still reach that 40. But yes, even though you're doing a sharp angle on a calcaneus, it still needs to be 40-inch SID. You have to play with it a little bit. That's something on that fact, that's probably the position that messes people up the most this semester is that calcaneus, that axial view, because that angle is very sharp and it really throws people off with the SID. Make sure you're checking that tape measure when you put that sharp angle because your SID does change quite a bit. You have to make those adjustments to keep it centered, part, cassette, and have SID. It's a bit of a balancing act. If there's one you need to practice the most, it's probably that one. That one really messes people up a lot. We'll talk about when we get closer to the positioning here. I'll show you some tricks that I've learned along the way. Okay, our KV range for all the positions in this chapter, they're going to vary from 50 to 70 KV. 70 more so in the knee tib fib area. 60 would be in the ankle and the foot area, and 50 would be reserved for the toes. Some good points there. Toes 50, ankle and foot 60, tib fib and knee 70. Your average KV for each of those parts. Short exposure times, as with all extremities, we want to have short exposures to make sure they are actually exposed properly. We would never do a long exposure time on an extremity. It would not come out correctly. Small focal spot and detail screens for analog. We always want that smallest focal spot selected as possible. Once again, extremity work, you must have a small focal spot to have the proper quality visualized on your screen. Adequate mass depending on the parts. When we get to the knee, the mass does increase quite a bit because it is a very thick bone. Then grids for anatomy that may measure over 10 centimeters. Not something you have to worry about so much more because everything's digitized. But if you're still using CR, sometimes they recommend you measure the parts. If you have a part that's over 10 centimeters, you would crank up your mass and KV accordingly to make sure you're getting adequate penetration for those parts. But because most of you are using digital these days, that little fact doesn't really apply quite as much anymore. But if that part did measure over 10 centimeters, you'd want to use a grid because you're increasing the mass in KV to absorb scatter radiation. As you increase your mass in KV, grids become more and more important for absorption. Now, the grids you're going to have are going to be installed in your tables because when you do your knees, they should be done within the table. At least I hope that's what you guys are doing lab. When you do knees, you want to make sure they're actually in the table. That's that thicker body part. Grids actually in the table. Is going to clean up some of that scatter for you and increase the quality of that radiograph. All right, so we're going to get into positioning now. We're going to start with the feet and the toes. As far as our routine projections go, when we talk about toes, we have a typical AP, oblique, and lateral. On the foot, we have an AP, keyword medial oblique, and lateral. Very important to know that. Medial oblique is what we choose to do on our feet, not lateral oblique. And the special projections of the foot would be AP and lateral weight-bearing feet, which essentially means the patient will be standing as we take the x-ray. Weight-bearing refers to standing. Now you'll notice on the toes it says just oblique. The reason for that is depending on what toes that we x-ray, you're going to opt for that medial oblique or lateral oblique. For example, 2 digits, or really the first 3 digits, you would do a medial oblique. The last 2 digits, you would be doing a lateral oblique. Open those joint spaces up properly. Anyone have to take your shoes off this week, by the way, like I said? Do you guys have to take your socks off?
Daniel did.
Daniel, did you get a pedicure beforehand? No?
Unfortunately, no.
He said his foot was the best, so he voluntoed himself.
Oh my gosh.
That is not true.
Voluntoed himself. That's the puns today are just out of control. Out of control. Okay, so like I said, with the toes, guys, we're going to start with the toes. That, of course, is going to involve an AP, an oblique, and a lateral for our traditional 3 routine views. Very easy competency to get, by the way. These come in a lot at the hospital. Another great comp for you to grab really quick once you get through your test outs. Feet as well. Now for AP toes, we're going to have the patient either supine or seated. They're not going to be standing up. That's a very key thing to remember. We would not want to stand the patient up because that actually changes the x-ray. The patient's standing, that's going to be a weight-bearing foot. And we're actually going to talk about that position here in a little bit. But for toes, they must be supine or seated on the table. We want them to flex the knee and place the plantar surface of the foot directly on the IR. Plantar surface, once again, refers to the bottom of the foot. 40-inch SID. Now, on the AP only, we are going to apply an angulation onto our tube. That's going to be a 10 to 15 degree angulation towards the calcaneus or cephalic angle towards the head. The central ray will enter directly on the MTP, the metatarsophalangeal joint. That's going to be the 3rd one, by the way. If you're doing a general survey of the toes, if it's a specific toe, you would put that CR on the specific toe you're talking about. Let me say that again. If you're doing all the toes, your CR will enter the 3rd MTP. If you're specified on one toe, put your CR on that exact toe's MTP. So if it's the first digit, they all want the hallux, you'll put it on that first MTP. Second MTP, and so on. But a lot of hospitals, especially Harris Health, want all the toes on the x-ray. Therefore, you would go ahead and center at that 3rd MTP. Does that make sense? Yes. Okay. IR size, it depends on how many toes you are x-raying. If you're x-raying only one toe, you want to use an 8x10 landscape. If you're doing all the toes, you want to go ahead and use a 10x12, just depending on how large the foot is. That's where you kind of use your own judgment on that. A lot of people's feet are very small, so they would fit on an 8x10 fine. But the general rule is if it's one toe, 8x10, all the toes, 10x12, but both would be in a landscape orientation. Collimation to the part will be exceptionally important on toes. When it comes to toes, collimation is key because toes get burnt out really easily on x-rays. They're a little different than the fingers. Toes look very dark on radiographs. So the tighter you can get that collimation, the more you're going to light those toes up. It's very important to remember on those toe x-rays. If you have that collimation wide open, I guarantee you your toes will be burnt out. Your radiograph is going to be hideous. It's going to be very ugly. Now, as far as the orientation, we always want to hang the toes up so that the toes are pointed towards the top of the film. Same for feet. We don't hang them with the toes pointed downwards. We always want the toes up towards the top of the film. We're hanging that film. The way it's worded there, as if the patient was hanging from their toes. If you held them up by their toes, for example, same concept. Now this tech here, actually put that marker upside down. That marker should be turned the other way around. I'm not sure if one of y'all was going to ask that, but I said somebody was about to ask that. That marker should be the other way around. Now, one thing you'll see in Harris Health, guys, when toes come in, Harris Health does not do AP toes. They will opt for doing an AP foot. Then they'll do oblique toes and lateral toes. So I don't want that to confuse you when you get to clinic. We're teaching you AP toes where you collimate to just the toes. But the protocol of Harris Health calls for an AP foot, then oblique and lateral toes. And that's what you'll see when you get to clinic. Now, our evaluation criteria, we want the digits in a minimum of the distal half of the metatarsal demonstrated. So we don't need the entire metatarsal on there, only the distal half of the metatarsal. We don't want the toes to be overlapped. Now, as you know, a lot of patients present with their toes very curled and gnarled up. They'll overlap on top of each other. If you notice that, you want to try to separate those toes. If you have to use tape, if you have to use gauze, try to separate those toes. It's very important because it's very easy to have overlap going on with the toes. Make sure you separate those toes properly. And we do want the IP and MTP joints to appear open. Who here can tell me, how do we achieve those joints being open on AP? Because we're not doing an oblique. What's helping us open up those joints? What do you think?
10-degree angulation.
Very good. The 10-degree angulation, which is why we add the angulation on those toes to open up that IP and MTP joints specifically. And then, of course, optimal exposure factors. Very important, 50 kVp, usually about 2 mass, is going to be a general technique for a toe. It's very important, once again, to have that tight collimation with the correct technique, because this radiograph right here looks beautiful, but if you don't do it just right, if you don't have that tight collimation with that good technique, those toes will look very black, very burnt out. Ideally, we do want them to look like we see right here. This is an x-ray of the second digit, by the way. That's the second toe. How can I tell? There's your sesamoid bone right there, which is typically on the first digit. This will be our second toe. You see the marker is barely in the field. This is acceptable, by the way. We want you to get as much of your marker in there because you're doing very tight collimation. So you get the corner in that light field, that's still acceptable. So eye marker placement would be considered acceptable on that radiograph.
But you can't tell what side it is.
And I think that is a good stopping point for today, guys, because I got to get this SLC meeting started up. It's already buzzing at me. We're going to stop right there today, and we will pick back up with our positioning on Monday. We've got a lot more to go through here, but we'll start wrapping it up next week. Are there any questions on what we talked about today? All right, so I will be sending you guys the PowerPoint thus far. Also keep an eye out for the practice images I'm sending you. And one thing I really recommend you guys do, I'm sending them to you with all the anatomy labeled. The best way you can start studying that anatomy is if you go into Microsoft Word, or if you put the images on PowerPoint, you can do it yourself as well. There's a shapes feature up there in Word. Put boxes over the anatomy, cover up the answers, quiz yourself, and you can hit the delete key to reveal the answers. That's how I always used to study for my anatomy. It works really well, but challenge yourself. Don't just look at the words, cover them up, and see how much you know. That way you know where to focus on when it comes to studying that anatomy. And study the anatomy hard, guys. There's a lot of anatomy that flew at you this chapter. Start studying it now. We've got a lot of positions that we're adding to it moving forward. So start studying now. To have our test coming up, I believe next Friday is when I have it scheduled. Yes, for the image review. So that's coming to you really fast. What else? I think that was it, guys. Have a safe weekend. Stay warm. Have a wonderful Halloween. If any of you guys wear any costumes, you take pictures and share them so we can see what you look like. See what your costume is if you're wearing anything for Halloween. I don't know if I'm wearing anything yet, but if I wear something, I'll let you know. I'll take a picture for you. Anyways, have a wonderful weekend, guys. Have a wonderful Halloween. And I'll see you guys bright and early on Monday. See you soon. Bye-bye.